Okay.
You see it now?
You got it now.
All right, so we're now recording. This is going to be the discussion on the humerus itself. And again, we talked about on page 144 the essential views of the humerus. And I also want to tell you, you see it's got AP, lateral, and then it's got lateral for known or suspected fracture. That comes into play with the transthoracic. And for the transthoracic, we have, that's going to be the upper portion of the arm. We have to include the elbow portion, and we also have to include AP trauma view. So we're going to go back to that and add to it. That's what they're talking about in the fine print here, where it says the humerus is usually imaged using the bucky if possible. The lateral projection for the distal humerus does not use the bucky. And I'll explain that when we get there. All right, so going next on. All right, now we're back on page 148. I'm not an anatomy person, but we have time. Looking at this, obviously it's a long bone. The head articulates with the scapula to form the shoulder joint. The head articulates with the scapula to form the shoulder joint. The distal end forms the elbow joint. Remember I told you there's no such thing as joints? Did I tell you guys this? Go get me a shoulder joint. You can't do it. You'd have to bring me how many bones? Minimum of 2, probably 3. Clavicle, scapula, and the humerus, right? Okay, so that's what we're getting at here. But anyway, you know, I'm not big into anatomy, but you do need to know this. You know the elbow. So let's talk about the humeral head and the parts that you have to know. There's two tubercles, the greater and the lesser. And in lab today, I have some humeruses pulled out. We'll look at them. And Ms. McKnight, if y'all could do the same today in lab. There's a deep impression on there's called the bicipital groove. And on both sides of that ridge, there's the greater and lesser. That's the two big parts that you have to know in relation to the epicondyle placement and the hand placement. And you kind of know perpendicular and parallel with the epicondyles, right? Now you're going to need to tell us what happens to the lesser and greater tubercle as we put the epicondyles either parallel or perpendicular. Any questions? We already know the elbow part, right? We just need to incorporate now with the epicondyles being parallel or perpendicular, what happens in the upper portion, the proximal portion of the humerus as far as the greater and lesser tubercle. One's going to be in profile and one will not be. All right? So everybody understands a long bone, it has the head. The anatomical neck is right here, and then you have what we call the surgical neck. The surgical neck is the weakest spot of the humerus. That's where if you have a break in your fracture, that's where it's going to occur at, more likely, okay? The surgical neck and the anatomical neck, we know the head, the greater and lesser tubercle. All right, those are the two that we're going to focus on. I think I have one more picture for you, better perspective here. Do y'all see this little, can y'all see my map? No. Right there. All right, y'all see this groove? This is the bicipital groove or intertubercular groove, meaning it's between the two what? Greater and lesser tubercles. There's a big indention. Okay, that's what they're showing. Bicipital or intertubercular groove right there. And this is the two bumps. This is the lesser. And this here is your greater tuberosity. Those are the two that we're going to be looking at. We're going to be focusing on. Okay? Any questions? I got the elbow put back in here. Looks familiar? You should know it. Does anybody have any problems with this? This is a review here. I'm not going to cover it. I just threw it in here because this is the distal part of the arm. The arm is the humerus. The forearm is the lower part of the upper extremity. When we say arm, like here's an x-ray of an arm, we're referring to the humerus. Or we would say here's a forearm. Okay? Any questions about the elbow? Everybody understand the medial, the lateral epicondyles? Yes. How do we know which is which? How do you know the lateral versus the medial? Media epicondyle, lateral epicondyle, trochlea, capitulum. So we need to have the what? The capitulum is the cap. The cap sits on the what? Radial head. So that's on the lateral aspect. So y'all are learning something. So even though that forearm is not there, you know you've got the capitulum and the trochlea. So you know the cap sits on the radial head. So that's going to give you the what? Lateral epicondyle. You'll have to know that. So it's kind of like go with what you know. Go with what you've already learned. Don't make it harder. Okay, so when you're good at the elbow, you should be, because we've already tested over. You should know the anatomy. Start looking at it. Start thinking about epicondyles. It's going to, again, we're going to get into medial, lateral, superimposed. All right, does anybody have any questions about the anatomy of the humerus? What your focus needs to be on is going to be the shoulder, the upper, the proximal humerus, because that's new material. The lower distal portion of the humerus is going to be a review for you, but we're still going to use it as a positioning guide for the humerus and the shoulder. So we're going to go right back down to the elbow, and we're going to start palpating those two little knots that we've been palpating for a month now in school, right? Epi and lateral epicondyles. That's why I ask, if you have a problem, if you don't have clarification of that, ask the question. It's okay. But you can't go any further in anatomy if you didn't get the elbow and the epicondyles and the understanding parallel perpendicular. You're not going to get it for the shoulder, because it's the same thing. We're going to be talking about it, but we're going to be talking about the reference of the epicondyles to the greater and lesser tubercles in the shoulder. Everybody okay? Head shakes, yes. Okay. Am I going too slow? Am I talking too much? I have a tendency to rattle on. Y'all can tell me to rush it on. All right. There's a picture of an AP humerus. How do I know it's an AP humerus? Real quick, Mark.
Because the epicondyles are facing medially and laterally.
Exactly. Look at the elbow. Look at the distal portion of the humerus. It looks like an AP elbow. Look at the olecranon fossa in the middle. Dead giveaway. See how quick you can do it? Just from what you already know. You know what this down here, my mouse there. Look at this. Doesn't this look like an AP elbow? Very familiar. You've looked at it, you've studied, you've tested on it. So go with what you know. You don't know anything about this upper portion up here yet, but you know the elbow. So he saw the olecranon fossa. He saw the two epicondyles. So that's telling you that was an AP humerus. Do you see how I'm doing it? So I'm building off of what you should already know. Now, if anyone is behind and don't feel comfortable speaking out loud, which I wish you would, get to a faculty member this afternoon and say, can you please explain the epicondyles? Because I don't understand parallel perpendicular. I think everyone should understand it. I think there was like 8 questions total between the lecture and the image critique that dealt with that. Y'all agree? There was a lot. Yeah. All right. So on page 211 in your book, we're going to be talking about some of the positioning parts of it now. So we're back to where I was reading about the pathological conditions. This is talking about actually positioning of the part. Place the top border or the IR or light field approximately 1.5 inches above the humeral head. Slightly abduct the humerus from the body and supinate the hand. So when you're supinating the hand, what are you doing with the epicondyles? Making them what? Making them parallel. That's right. All right. And it says a coronal plane passing through the humeral epicondyle should be placed parallel to the IR. This is the humerus, and we're still talking elbow anatomy, right? Is everybody understanding that? Just a kind of a continuation. It's a long bone, so it says central ray is perpendicular to the mid portion of the humerus and centered to the IR. There was a question that we were talking about this, I forget, it was one day last week. Can you do something diagonal, or do you have to keep it up and down straight? You can certainly work diagonal. Diagonal corner to corner gives you a little bit more room on those boards to get long bones. So yeah, absolutely you can. All right, do you have any questions on this slide? Any questions at all? This is position apart. It's on page 211. Place the patient in the seated, upright or standing position. And right there towards the bottom under position apart on page 211, it says the body position, whether oblique or facing toward or away from the IR, is unimportant as long as the AP radiograph of the arm is obtained. So what is that telling you can do here? Any idea? Y'all see where it's at in the book on page 211 under position of part, the second bullet. It says figure 5.1.5.1 illustrates the body position used for an AP projection of a freely movable arm. The body position, whether oblique or facing towards or away from the IR, is unimportant. It doesn't matter what you have to do to the patient to get the arm in position, as long as the epicondyles remain what? Parallel. Okay, if you have to turn the patient a little bit away from it, towards it, whatever it takes, as long as you keep the epicondyles parallel, you're getting an AP humerus. Mid shaft makes sense, right? Long bone, mid shaft, middle of the humerus for your central ray. Any questions? Next slide. Okay, this is evidence of proper collimation. Anytime you're doing a long bone, you have to show the articulations on both ends, which was true for a phalanx. It's true for a humerus. We have to show the entire shoulder joint, and we have to show the entire what? Elbow joint, right? It says joint to joint. Elbow and shoulder joints have slightly distorted due to beam divergency. Does anybody understand that? Does anybody understand divergency of the beam yet? No, it's okay. Okay, so our x-rays come down from a pinpoint, and as they travel, they disperse. They spread out. Just like when you take a flashlight and you put it real close to your hand and you pull the flashlight away, what does the light do? It spreads out. It gets what? Bigger, right? That's dispersion. That's what x-rays do. So for those joints to be open, Dr. Curtis told you with the hand, in order for the fingers to have open joint spaces, the central ray had to be what? Perpendicular to the joint space. Didn't she tell y'all that? Kinda. Y'all remember this? So it's telling you right here, your shoulder and your elbow joint, because they're going to be, you're centering in the middle of the arm. The two joints are so far away from the central ray, they're going to have a slight distorted look to them. Okay, but we're doing this for the arm. We're not doing this for shoulder. We're not doing this for what? Elbow. We're doing it for the long bone of the humerus. So do we care whether or not the elbow or the shoulder joint slightly distorted? No, because we're doing it for the arm. If we wanted to do an elbow, we'd be centering over the what? The central ray would be directly over the elbow joint. If we're doing a shoulder, which we're getting to, you will center over the shoulder joint. So when you have a long bone and you're centered over the middle of the mid shaft, obviously the joints themselves are going to be slightly distorted because of the divergency of the beam. The only part of the beam that is going to give you a true representation of the anatomy is what part? Sir? The center? Is that what you said? Central ray. CR. That's why the book keeps talking about the CR. Central part of the beam. Those are the only x-rays that are traveling in a straight line. Those will keep your joint spaces what? Open. So the further you get away from the central part of the beam, they start at an angle. The angle causes what? Joint spaces to close, right? Is everybody that's a little physics, I know. But Dr. Carter says she talked to you about distortion. Everything had to be on the same plane, otherwise you have what? Distortion. Remember now we talked about the hand, right? The finger, the oblique hand, how each finger had to be parallel to the IR. You couldn't allow the tips of the fingers to touch the IR because there was a variation of what? OID, right? That's a distortion, type of distortion. Any questions? Sienna, you good? Repeat everything I said? I love to do recaps, by the way. I'm just not picking on you. I'm just wanting to hear that you're getting it. Are you good right now you think you can do a quick recap?
No, thank you.
No, thank you. I'm coming back to you now. Okay, I'm going to let you slide on this one because it was you didn't quite have a heads up on that one. But I'm coming back to you to do a recap. All right, so AP humerus, evidence of proper collimation. Elbow and shoulder joints should be slightly distorted due to the beam divergency. We just took off on a tangent to explain beam divergency. Everybody understand it now. You're not using the what? Central part of the beam over a joint, so the joint will not be open and true representation is going to be distorted. All right, humeral epicondyles without rotation. Outline of the lesser tubercle located between the humeral head and the greater tubercle. Bony trabecular detail and surrounding soft tissue. Have you seen that in a lot of your evaluation criteria? Bony detail, bony trabecular pattern. That should be a given. All right. Outline of the lesser tubercle located between the humeral head and the greater tubercle. I think I got a picture coming up for you. Here's the patient being done. You can do it standing, which we said was the more what? Easiest for us to position and more less discomfort for the patient. Think about it. You got a crushed arm. You got to crush something in your extremity-wise. Standing up, protecting that arm is easier and makes me feel more secure than laying on a table and having the weight of your body pull that arm. But it can be done whether it's done erect or supine, recumbent. All right? And I think that's actually on page 211 and 213. They have the recumbent. All right. Any questions? That's the AP. Epicondyles will be what? Parallel. We're going to make sure we're including joints, the shoulder joint and the elbow joint. So the central ray will be at the mid shaft of the long bone of the humerus, right? Okay. All right, evaluation, entire humerus is demonstrated. Yes, greater tubercle in profile. Here it is right here. Y'all see this little outline, this little white outline right there? That is your greater tubercle in profile. Medial and lateral epicondyles, look, here they are down here. So again, you know that. You know the elbow, right? So you can go right here and say, okay, that looks like what? AP elbow. So I must be looking at an AP humerus, just by what you already know about the elbow. The exposure factors we'll get to. I think there's a chart in here I want to discuss with you in a little bit. Okay, so any questions about this picture, this image? This is an AP humerus. Everybody good? Michaela, you good? Mr. Wilson? Mr. Johnson?
Nods up here.
We got nods. We got questions?
No, sir.
All right, we're moving on. Okay, we're on page 212 now, and it talks about the lateral projection. I want you to look at the very top of that page on 213. I'm sorry, 212. Look at the two positions or projections, I should call them: lateral, medial, medial, lateral. So what does that tell you? Sir? Not that you have to do them, but you have the opportunity to do them either way. Okay, either way, it can be a lateral medial or a medial lateral. That meaning from doing it from the front or doing it from the back. And if you look at your images on that page on figure 5.153, 154, you see the difference. But the outcome is going to be the same as long as we're cognitive of the epicondyles being what? Perpendicular. Very good. Perpendicular, because it looks like an elbow, lateral elbow, doesn't it? Everybody see that? All right. And it says, again, this is under position of part on page 212. The body position, whether oblique or facing towards or away from the IR, is not critical as long as a true lateral projection of the arm is obtained. How do we know it's a true lateral? The epicondyles will be what? Perpendicular on the image. They will be what? Superimposed. It's not rocket science. You know this stuff already. Look how good you're getting at it. So we're focusing on the elbow because that's what we already know. Okay, it says, let me see if I think I got all this on the next slide. Place the top of the border the same as the AP. You're going to have 1.5 inches above the humeral head if possible. Internally rotate the humerus, flex the elbow 90 degrees, and rest the palm of the hand on the hip. Coronal plane passing through the epicondyle should be perpendicular to the plane of the IR, the central ray perpendicular to the mid portion of the humerus. We talked about that. It's the same as the AP. And center to the IR. So it's talking about the placement of the hand. The palm should be on the hip. The flexion of the 90 degrees, I've looked at it in different books. It's not necessary as long. It's easier when you do it because the epicondyles go naturally superimposed when you get that little bit of flexion away from the body. But as long as you have the epicondyles perpendicular, right, you have a true lateral humerus. And it looks just like a lateral elbow, doesn't it? Any questions? The one thing on page 212 in the middle of that, there's a contraindication. What does that mean? What does contraindication mean? Sir? Should not do it. It's contraindicated. So we can't do it. If it's something contraindicated, it means we have to think of another way of doing it because we can't manipulate the arm. Contraindicated. That's on page 212, middle of the column. Unless contraindicated by possible fracture, internally rotate the arm, flex the elbow 90 degrees. This places the humerus in a lateral position. A coronal plane passing through the epicondyle should be perpendicular. And the next bullet, it says a patient with a broken humerus be easier to position by performing in a medial lateral projection as shown in the figure 5.154. Everybody see that? I can tell you, and Ms. McKnight, you can speak on this. I've always done mine on the top image. I've never done mine from the back. Regardless of how the patient came in, I was always able to get them done this way. So this is going to be what? Lateral medial, right? Going this way. So I saw that on there. I said, well, I've never really done one of that, but it makes sense. If the patient's holding that arm, and it even tells you about that, it says if the patient is not already holding the hand of the broken arm, have them do so. That's on the third bullet, second bullet underneath the position of part. So they're saying just if they're holding their hand, they know they have a broke arm, holding it, you can actually shoot them from the back and get the same image. Okay? And they can continue to hold their arm. All right. Respiration for all of this is going to be suspend. And what does that mean to a patient? Hold their breath? No. Suspend. Stop. Wherever you're at in the process of breathing, I want you to stop. And in our lab, that was one of my big drills, was it not? I said, I want you to incorporate breathing, respiration, whether the hand moves or not, because I want you to create good habit. And it's fixing to happen to us where we actually have to suspend, take in a deep breath for the clavicle, breathe like a dog, panting, doing a breathing technique for the transthoracic. So respiration's fixing to come to where it's very important. And you have to understand and you have to mention it. Right? So we understand suspend is just stop wherever you're at. Stop breathing is different than hold your breath. Don't you think? Because when I say hold your breath, patients have a tendency to do what? They want to inhale first. It's like taking a deep breath and hold it. We didn't say that. That's a chest, right? So we could build off of that for a chest x-ray. Take in a deep breath, blow that one out, take in a much deeper breath and hold. This says suspend. Just stop where you're at. And my thing is stop, hold still, don't move, hold still, don't breathe, beat. Breathe and relax. That's what I want to hear because you're hitting all your marks that you need for that lab test. All right. Any questions on this, guys? Let me see. Let me see the next one, Scott. All right, here it's just the pictures of them showing the lateral humerus. Yeah, notice it's a different person from your book. Did you even notice that? I tried to make it interesting. This comes from a different positioning book. I got tired of looking at the same little person. So I was like, okay, we're going to throw some new people in here. All right, lateral humerus, you're going to have evidence, like proper evidence of collimation. Same thing, superimposed epicondyles. Lesser tubercle is in profile on the medial aspect. We'll get to the lesser and greater more so when we talk about the shoulder. The greater tubercle is superimposed over the humeral head. The bony trabecular detail and surrounding soft tissue. What of all of these bullets, what can you use to be able to tell what you're looking at that you already know? The superimposition of the what? Yes. We don't have to go with the greater and lesser tubercle yet, even though it's mentioned that, right, they're opposites on the lateral and the AP because of the placement of the hand. But you already know the epicondyles. So if you had two humeruses, you could look at them and you can tell me which one is which just by looking at the distal portion of the arm, which we call the what? Elbow joint. And you already know how to evaluate that looking at the epicondyles. So this should be a little bit easier for you because you already know the distal part of it. We're going to be talking about the shoulder joint with the greater and lesser tubercles. But you don't need to know that right now with just the humerus because you know what the epicondyles are doing. Yes? Is this making sense to you? Is this making it easier for you to understand? This doesn't have to be hard. We always say build on what you already know. If there's something in the picture that you've already been studying, which a humerus, in order for it to be a humerus, it has to have both joints. Well, you know one joint is called an elbow joint. You've already been tested over it. Focus on it, right? Until we learn the proximal part of the humerus, which becomes the shoulder joint, which will be new material for you. Okay? All right, lateral evaluate. Look at this quickly. Look at this, Mr. Wilson. What do you see? Just look at the image.
Superimposed epicondyles.
Tells you it's a what? Boom. You see, you don't have to go through all the rest of the tubercles, facing or all. You don't need it. You just need to know, obviously it's a long bone, but you're looking at that elbow and I see the epicondyles are superimposed. So that tells me they were perpendicular. So this must be a lateral. That easy. Any questions? All right, transthoracic. Oh, I thought I put, I think it's on page 236, guys. This is the one we've been debating on, and it's gotta be mentioned. Dr. Curtis put her 1 through 9. This is her PowerPoint. She loaned it to me. She put her 1 through 9s in there, and I do want to tell you there's an additional 1 through 9 that she added yesterday for the partial flexion and extension of the elbow. So you may want to go back and print that 1 page off to add to this stack. All right. So transthoracic lateral projection. I'm on page 236. Top of the page. You need to know the projection. Sienna, and it's called a transthoracic. Listen to the words. Trans means to go across. Transcontinental means you're taking a flight across what? The continent. Transverse means you're detaining the tube across the table. Transthoracic. So we're going across the what? Thorax. Right? Transthoracic. It also has a method name. Is this our first one to have a method name? It's called the Lawrence. It's called the Lawrence. It's on page 236. You got your essential little element there, and it's got the word transthoracic lateral projection. Test question. Also, it tells you the method name is the Lawrence method. The person that decided how to do this was given credit by naming it his method, Dr. Lawrence. So you have to know projection and you have to know the method. 2 test questions. All right. It says the Lawrence method is used when the trauma exists and the arm cannot be rotated or abducted because of an injury. Can't do nothing. We have the arm is stationary. It's to the body. They come in, they're holding their arm against their stomach. They may be in a sling. We can't move the arm. We have to figure something else. How are we going to get a picture of this? Right? They're holding it snug to their body. It's a protective thing. They, holding it by the elbow. So we have to figure out how are we going to get, we can do one straight like this. I don't even know where my phone's at. Oh, no. That's one of my doctors. But anyway, I lost my train of thought. What was I talking about, Sienna? So we can do one fixed like this, right? Put them against the bucket and shoot it this way. But can we get one at 90 degrees from that? No. So we're going to have to shoot straight through the body, the thorax, from the opposite side to get this. Right? Transthoracic. Does everybody understand that? So the person's coming in. Can y'all see me on the screen? I don't know what they're seeing. Angie, can you see me? Because that camera's way over.
No, the camera's facing more at the corner.
Man, is it way over here in this corner?
Yeah, we see you. Yeah, huh?
Okay, so if a person comes in like this, sling, whatever, we can certainly get one of the proximal humerus, put their back against the board and shoot this. How are we going to get the other one that's 90 degrees from it? We can't really, get this one, but we can't do anything else. So if we turn on this way with the affected arm against the bucket, raise this arm up, shoot through the thorax, we'll get this one. Transthoracic lateral. What's the method? Lawrence method. Transthoracic is your projection. Everybody kind of understand that? All right, again, we're on page 236. This is done when a patient cannot move their arm. Post-surgery, we know there's a fracture, an obvious fracture. They just don't want to do it, but we have to work with it, okay? It says, although this projection can be carried out with the patient in the upright or supine, the upright position is much easier on a trauma patient. You hear that a lot with all of your upper extremity. We can do all upper extremity on table. But if you come in and you're crushed up, your arm's all crushed up, you're protecting it, am I going to ask you to lay on a table? Or is it going to be easier for me to stand up? I guess I'm over here on camera now. Am I going to get you to stand up and put the vertical bucky and be able to manipulate you without really touching you that much? That's where this is coming from. But can you do this on the table? You can certainly do this on the table. Okay, we're not saying you can't, but we're saying for patient comfort, the preferred is to have them done erect. Everybody got that? Everybody good? All right. 1 through 9s. Everybody have your own 1 through 9s? I should put it in here. The one thing that if you notice on this screen, the word breathing technique is highlighted. I went through and I highlighted that right over there in yellow. We're going to, Ms. McKnight, make sure y'all cover this in lab. I had group B. Was that group B Thursday? I have 2 pros now. I'm going to make 2 pros in this group today. I'm going to introduce the world of technique to you. And I'm going to show you how to do a breathing technique. A breathing technique is simply that. The patient is actually breathing during the exposure. So what do you think is going to happen? What do we tell patients to do in radiology before we make it their exposure? Hold still, don't move, don't breathe. Now we're going to tell them to do what? Breathe. So what is that breathing going to do? Breathing causes motion in radiology. That's why we tell our patients to do what? Hold still, don't breathe, hold still. Now we're telling them we want them to move by breathing. The breathing will blur. It will blur everything out except what's touching the IR and is stable. So when you're standing like this, the injured arm is pressed to the vertical. It's not moving. The thorax is moving because you're breathing. So all of this will blur out and you got a beautiful picture of the proximal humerus. And it requires a long exposure time and a very, very low MA station. Do y'all know you ever heard of that before? MA stations? Mass? KVP? What have you heard? As far as technique, you're a radiology student. What have you heard? You know what KVP is? It's okay. Yes, no? No? Am I hearing no? Or it's hard for me to see when y'all's faces are covered with a mask. Never heard of KVP? Intro, you never heard of it. Mass, MA, time. Remember that kind of sort of? Well, that's what we're going to learn today in lab. We're going to manipulate mass to where we're going to get a very long exposure. Your normal your AEC work, that's what you're accustomed or will be accustomed to using, it sets everything for you, and there's a timer that goes off when you reach the exposure. It automatically does it for you. We're going to learn how to control time ourselves and set our own time. Because for motion to occur, we have to be working in seconds, not milliseconds. Okay, we need to give the body, the patient, time to allow the motion to happen. We can't do millisecond exposures and expect them to take 3 breaths in. Okay, so we're going to be talking 3 to 5 second exposures. And that's called a breathing technique. Everybody got it? That means we have to have a technique in our heads for using breathing to our advantage. The breathing technique, and that's for the transthoracic. We want to blur out the lung field, the ribs, And the only thing we want in focus is going to be what? The humerus itself, right? The proximal portion of the humerus. Remember, this is what we're going to focus on today in lab. I'm going to show you how to get to the control panel. I'm going to show you how to set it up. You need to understand a breathing technique. It turns out beautiful. All right, so I do want to, like I said, teach you that. And Miss McKnight, if y'all can do that on your end, that'd be great.
Yes, sir. Hey, Kendall,
yes.
or Mr. Delisard, when were you wanting to stop the recording and start again?
I'm almost done with this one.
Okay.
So I'm gonna stop this after we do partial flexion and extension, and then we'll go to the shoulder joint.
Gotcha.
All right. So that's on page 236, guys, on the third column. It says if the patient can be sufficiently immobilized to prevent voluntary motion of breathing technique can be used to blur the pulmonary vasculars. In this case, instruct the patient to practice slow, deep breathing. And how many seconds do we need? A minimum of 3. 4 to 5 is even better. So highlight that. Remind me, we're going to teach you that in our lab today. All right, so proximal humerus is demonstrated. The scapula, the clavicle, the humerus is seen through the lung field. The scapula is superimposed on the T-spine, the unaffected clavicle and humerus above the shoulder of interest. This is all what's being demonstrated on your transthoracic. Here's the body part. Here it is positioning. The one thing you want to do, you want to get the unaffected arm. You want to get this arm. You want to get it really high. Okay, so you're going to stretch this one, and at the same time, the affected arm, you're going to ask them to lower it. So what you're trying to separate are the humeral heads. So this one's going to go up. This one's going to go down. Okay, that's what they're talking about. Obviously, we can do it again. We can do it erect, or we can do it supine or recumbent. All right, and this is what it looks like. Look how pretty that is. And you see look what's dead center. Humeral head, and this is the proximal humerus. They got your unaffected clavicle. Here's your scapulus. Clavicle again. You see the little V right here like a wishing bone? Those are your 2 clavicles. Everybody see that? We got some more images we'll be looking at. All right, there's your humeral head. Here's again is the lateral border of the scapula. And what we're after is the proximal humerus. And this is only done when a patient cannot manipulate a hurt or injured arm. There's another way around it, and we're going to be shooting what? Across the thorax. So it's transthoracic. Lawrence method. Requires a long exposure time in full seconds. Okay? All right. This is the other part of it. We've got the proximal. Now look at this one. This is a trauma view. All we do is put the plate. The epicondyles are what to the plate here? Perpendicular, right? But look where the IR is. So we're going to be coming with a what? Horizontal beam. Everybody with me? This is on page 215. This is going way back now. This is the lateral. This is one of those trauma views. But this is the other part of the transthoracic. We got the upper. We have to include the distal part now. No rocket science here, right? You put the plate there and you center. The plate is, the epicondyles are going to be perpendicular, so that gives you a lateral perspective of the distal humerus. Everybody okay? This is on page 215. Y'all good? As long as the epicondyles are what? Perpendicular. Look at the image. Let me show you the image. There's your image. Looks like a lateral elbow to me. Right? But it's used with a horizontal beam. So it's a little critical thinking there. But there's a lot of ways to get these images. All right. Partial flexion and extension is what I've been kind of talking about this morning. This is the new 1 through 9 that Dr. Curtis has put in y'all's Moodle shell. It's there, print it off if you want it. Okay. AP elbow distal humerus partial flexion. I thought I had the page numbers on this. It's back under the elbow. Page 200. So let's go back to page 200 real quick. I know I'm running long on this. I said I was going to do short snippets. So I'm on page 200. And what does it says? Distal humerus. Distal humerus. Partial flexion and extension. Patient comes in, their arms like this. We just showed you how to do what? The lateral distal humerus, because the epicondyles are perpendicular. Now we've done the transthoracic for the proximal portion. That was for the distal. How can we get the AP now? We have to get an AP. The arm is going to be kept in the 90 degrees. It's going to be like this. And this is going to be for the proximal forearm. Then it's going to be like this for the distal humerus. And those put together gives you an AP elbow. Okay, and this is on page 200, 201. Okay, so it says, can be used in place of an AP projection of the elbow when the patient cannot completely extend the joint. Remember, they come in like this. So we're not going to like, oh no, we got to straighten your arm out to get an AP. We're going to work with it, right? We're going to do our distal lateral humerus. We're going to do our transthoracic for the proximal. Now all we have to do is the AP elbow, and it's this and this. Okay, everybody see that? This is for what? The distal AP humerus. This is for the what? Proximal elbow. Right? That's why I feel like this should have been thrown in with the elbow section. All right. Okay, so let's look at on page 200 in your book. Let's see what else I have on here if I got a picture of it. Yeah, I want to show you the picture. Right here. Look at this picture here. What do you think was in contact with the IR? Was it the radius and ulna, or was it the humerus? Can you see the radius and ulna are in detail? And the distal portion of the humerus is blurred out. That means that it was raised up off of the IR. So depending on what part of the elbow in that 90-degree flexion, if it's going to be this touching the IR, it's in detail. This will not be. When you go like this will be in detail. This will not be. So you should be able to look at the image and say, okay, what's in detail? I know it's partial flexion and extension, but what is it used to demonstrate? This is demonstrating the proximal forearm because it's in detail, right? Does everybody kind of understand that? That's all on page 200 and 201. We will practice this in lab, and yes, this will be on your lab draws. It's an elbow. It's just keeping it in that idea that the patient can't or is limited in their movement, and we can work with it. If they're in a cast, we have to do them like that. Okay? All right. So, Sienna, what's that a picture of? I'm sorry? The humerus? The humerus, what projection? I love she looked straight down at the elbow. And that gave it away, right? Because you see the what? The fossa. You know, the epicondyles are on the side, so that is an AP humerus. All right. Okay, I'm stopping the recording, Miss McKnight.